Ladies and gentlemen, we have now come to our second guest lecture for the day on interventional pulmonology, past, present, and future. And with that, I cordially invite the chairpersons, consultant respiratory physician Dr. Geetal Pereira, consultant respiratory physician Dr. Vipula Bhattacharjee, to introduce the speaker.
Good afternoon. Next, we have our second guest lecture, which is on interventional pulmonology, past, present, and future. It will be delivered by Professor Phan Tien Nguyen. He is head of the unit of Department of Thoracic Medicine, Royal Adelaide Hospital, Australia. Over to you, sir.
So thank you to the college. I think Prof. Wells mentioned the Sri Lanka versus Australia World Cup final last night, and I have to say that I was very sad when Australia lost to Sri Lanka, so I thought I'd just bring that up today. I always like to start with a slide to embarrass my Sri Lankan friends, both past, present, and future. So Yamuna and I had a nice dinner the other night. She trained with us in Adelaide many years ago. Now, Dr. Amitha, I think I've embarrassed you with the medical school with this photo before, but he is an expert in guessing a song from the first 3 bars, and that song was Give Me Hope, Joanna. And the last photo was at our IP workshop on Saturday, and I was very, very humbled to be teaching at that and for the invitation. So there were 2, I guess, quite useful papers which I accessed for this talk. I think this comment is probably the most important comment from today. The best, I guess, doctors or bronchoscopists know when not to perform a procedure. Then one of our friends in the Asia Pacific region, Ping Li, and Ashutosh did a recent update which was just published in Current Opinion in Respiratory Medicine earlier this year. Now, we often talk about Gustav Killian as performing the first bronchoscopy. So the theme of WAPIP in Melbourne 2026, Rajesh Thomas is the chairperson for that Congress, is celebrating 150 years of IP. The story is that Gustav Killian, who was an ENT surgeon, performed the first bronchoscopy in 1876. And the reason I've written pork chop there is that's the foreign body that he removed at the time of that first bronchoscopy. Moving on, Dr. Jackson developed many rigid instruments which he self-designed. He added suction and lighting, and he was obsessive about keeping records. Sometimes I think Prof. Lee's obsessive about publishing, but this man kept a record of every foreign body that he removed, and there were 2,300 in his lifetime, so I don't know what was happening back in the 19th century, but people were not swallowing their food very well. I think the other thing to mention about Dr. Jackson is he established teaching courses which encourage people to come and practice IP, and I think that's something that's been very important to today. The other turning point was Dr. Akita, who developed the first flexible bronchoscopy, and that's his model there. And he unveiled this in Copenhagen in 1966. There were some questions from the trainees about using your left hand or right hand. Yasufuku told me, well, the cabling for the bronchoscope comes out on the left, so you shouldn't use your left hand. In the early days, everyone used their left hand because they wanted to copy Dr. Akita. He used his left hand, so everyone wanted to be like him, so lots of people used their left hand. So then we move on to transbronchial lung biopsy in the 1970s. This was before I was born, but this is probably still the one procedure which sometimes gets respiratory physicians nervous because of the risk of bleeding. We feel like we can deal with the pneumothorax fairly well. They had a rate of almost 20% in the first 150 patients. That dropped to 11% in the next 300 patients, and most published data nowadays suggest a rate of about 1 to 2%. Dr. Wang was the next pioneer. So we did a course on EBUS on Saturday. In the early 80s, Dr. Wang showed the anatomical landmarks of the mediastinal nodal and hyalonodal stations. And he demonstrated that you can access these nodes blindly, essentially, with a needle down the working channel of the bronchoscope, with fairly minimal complications, but obviously the yield is highly dependent on the proceduralist and his or her experience. We have a doctor named Dr. Dang in our department, and I trained with him at the time, and his hit rate for TBNA was very high, and we used to call it the Dang needle in our MDTs. Obviously, Jean-François Dumont has to be mentioned as a pioneer of IP and still thought to be one of the godfathers of IP. He really rejuvenated the rigid bronchoscope in the 80s when he started to develop devices which could place stents. He also developed teaching and education tools and accepted a lot of trainees from around the world into his institution to promote the field of IP. So then we move into the era of ultrasound, and I think that's probably the third era which has made a big difference to the management of patients. Dr. Becker, Herter and Hohenrath published on the first experience with ultrasound. So I often tell my trainees that they do a lot of linear EBUS nowadays, but the first TBNA done with ultrasound was actually with a radial probe, like the balloon that you can see there. So the proceduralists would put the balloon onto the target lymph node, memorize where on the clock face that lymph node was, take the balloon out, put the needle back down the working channel and then puncture that area. The other utility which was demonstrated was that the balloon could show the 5 cartilaginous layers of the airway. So back in the 90s and early this century, there were a lot more central tumours in the Western world because of high smoking rates. And some of these central tumours were carcinomas in situ. And we needed ways of determining whether to treat them locally with, let's say, laser or APC, or whether they needed a more definitive treatment such as radiotherapy or surgery. There's a very small study done by Miyazi which showed that the ultrasound could tell you when it had invaded past the 5th layer, and in those cases you had to do something more definitive than local therapy. So those two pictures are just showing the cartilaginous layers that we were able to demonstrate with the balloon. Now with the improving imaging of the bronchoscope and the high definition of the bronchoscope, the balloon is felt to be less needed. So the convex probe ultrasound, Kazu Yasufuku was essentially the pioneer of this device, and Gary and I joked with Rajesh that we were able to pull Kazu away from Canada for a short period to come and teach with us in WA last year, and actually get him to stay for 1 or 2 days of social events. So we ran a similar course which was run on Saturday, and he really changed the nodal staging of lung cancer patients and of other cancer patients early this century. So then we moved on to navigation. The first type of navigation was actually electromagnetic navigation. You have a special bed which you place the patient on. The bronchoscope has to be orientated with the landmarks within the patient, and then you can place a target on your nodule, a target at the centre of the trachea, and then the computer works out where to go in terms of the nodule, and then you follow it like a road map. So I might move on to lung volume reduction. Some of the current treatments include endobronchial valves, thermal vapor ablation, coils, and sealants. This is the history of lung volume reduction with endobronchial valves. Very early on, we were approached as a centre to be a first-in-human centre for these valves. But the lessons from the early studies were that there were two things that you really needed. You needed to occlude the whole lobe, and you needed to ensure that there was no collateral ventilation between lobes. So the theory was, even if you blocked all the airflow to a certain lobe, if the fissures between the lobes had communication, it didn't matter what you did with the front door, air would leak in through the back and you would never get volume reduction. So these studies over time, especially from the vent study, have shown that the importance of collateral ventilation in the management of these emphysema patients. These pictures are from Dr. Slebos and Dr. Karen Cloister in their review article in Chest. And here's a short video of a valve being placed. It goes down a working channel of the bronchoscope. You fan it out slowly, push it onto the distal carina, and then deploy the valve with a little catheter device. And you'll see that it opens and closes like a duckbill. So vapor was developed as another form of lung volume reduction. With vapor, it's a heat energy which destroys the lung tissue, and you have targets or segments which the computer tells you is the most diseased, and those are the targets that you aim for with your vapor. I guess the good thing about vapor is once you've put it in, the tissue is destroyed, you'll get volume reduction, and the fissures are less important. Now, it's still available overseas, but in our market in Australia, the distributor failed to update their 3-year data, and we unfortunately lost TGA approval for it in Australia. Coils, as you can see, there are many coils in this patient. There is, I guess, more moderate data for coils in lung volume reduction, and it's probably the second or third level of evidence, valves being the first, vapor being second, and then coils being the third. Gary and I had breakfast this morning and we were talking about closed pleural biopsies. Everyone in this audience would be very familiar with this. We also talked about how in the last few years, both of our centres have moved away a little bit from medical pleuroscopy. And we've gone to an ultrasound-guided pleural biopsy regime. So we do a lot of EBUS, and our mind has become very familiar with the EBUS image of the needle coming in from the top. So Dr. Rash Badiai, who trained with Gary after training at our centre, has started to do many of these procedures under ultrasound guidance. We reverse the ultrasound so that the needle comes in from the top of the picture. You can see the fluid in the background on the ultrasound screen there. We look for the thickened pleura, we look for any disease on the diaphragm, and we use the 10 mO needle, which is the same sort of needle used to take renal biopsies and CT-guided core biopsies in order to access the pleura. So we've moved to a more minimally invasive approach, similar to what WA and Newcastle in Australia are doing. Mostly all done under local anaesthesia and very, very minimal sedation. So that's a quick rundown in the first 10 or 15 minutes of where we are at in terms of the past and the present. And I just thought about a few things to talk about in terms of current and future challenges. I think for us in Australia, the big challenge will be the lung nodule. There'll be a talk tomorrow about EBUS staging for cancer. Yield and sample size are often a big talking point in a lot of the conferences now, and there's a lot of chatter about cryoprobes. Endobronchial treatment of malignancies, I think they're probably 10 to 15 years away. If you look at the SABRE data, it took about 10 or 15 years for the data there to mature. Treatments for chronic bronchitis, some of these are available commercially overseas, but not widely available elsewhere. And treatments for emphysema where fissures are not intact. And there was a comment in the inauguration yesterday about artificial intelligence and machine learning. So still another quote from Prof. Wells last night. He said, if you don't know where you're going, any road will get you there. And sometimes when I'm watching people do radio ultrasound, it seems like that's the philosophy they take. They'll just keep choosing different airways until they get there. I think one of the things which people in Sri Lanka can learn is the bronchial branch tracing, pioneered by Professor Kuramoto. With that technique and radial EBUS with II, our centre gets about a 75% yield. This is comparable to some of the studies which have used virtual navigation and electromagnetic navigation. And you see that even with navigation techniques, ground glass nodules are still a very big challenge in terms of diagnostic accuracy. And that 69% yield is actually in an expert Japanese group who do this every day of the week. And if you look at the acquired data from the US, when you look at the centres which contributed to that data, they were all expert centres, and their radial EBUS yield was probably around the 60 to 65% mark. So we talk about all these technologies and accessing nodules, and then you take a step back and you've got the patient in front of you, and you're almost quoting a 1 in 4 and 1 in 3 miss rate for your difficult nodules. So that's where I think technology with navigation tools and other technologies will help patients in the future. So I'd like to throw this photo in of David, who is my mentor, and Kuramoto, who is essentially David's mentor. That's his original photo of his airways, which a lot of the consultants in Brisbane used to carry around with them. So the other technologies are scopes which are getting smaller with a working channel which is still useful, and probably I find the middle ground the best here. The 4mm scope with a 2mm channel probably is, I think, the best balance. Some people like to use the 3mm with a 1.7 channel because you can still put diagnostic tools down it, such as forceps and the radial EBUS probe without the sheath. You add in navigational tools, you add in needling the nodule in the periphery. You can add in peripheral cryobiopsy, and then you can add in imaging in real time, such as cone beam CT or robotic bronchoscopy. So our PhD student, Michael Brown, just had this published in Chest Pulmonary, which is a new subsidiary of Chest, where we looked at the review of cone beam CT with radial EBUS, and most of the yields are around about the 80 to 85% mark when you look at the data. It's very dirty data, unfortunately. It took a long time to do the statistics, but we thought this was prudent to do because there's been an explosion in the number of centres in Europe and America in using CT to do EBUS-guided biopsies. So one day during COVID, when the hospital was very quiet, I walked past the radiology department with one of my radiology friends, and we saw this big OR machine in the corner, and I said, "What is that?" And he told me, "Oh, it's a portable CT." And I said, "Are you kidding me?" And he said, "Look, not a lot of people use it. The orthopedic people use it occasionally." And I said, "Can I ever borrow it?" And he said, "Yeah, sure." So it opens up like Pac-Man. You push it in, and you can take a CT on the table after you've accessed the nodule with your ultrasound or your biopsy tools. So we're doing a small trial looking at tool in lesion success rate. Doing a trial to look at diagnostic yield, you need to do hundreds of numbers. So really we just want to show a proof of concept that this can help you improve your tool in lesion success rate. So that's Michael standing in the corner there with the CT in place, and you can see here he's managed to do a fairly big U-turn to get the tool into the lesion. So a lot of the companies are developing portable CT arms such as this, and a lot of centres in America and Europe are starting to implement this into their practice for nodule access. The radiation on these newer technologies are also dropping as well. So I guess the other big thing is robotic bronchoscopy. The bronchoscope doesn't actually have a video in it. It's a 2mm channel, so you have to put the optic into the bronchoscope. and you use a navigation tool to walk yourself down to your nodule. Once you are there, then you can take out the optic and then put your tools into place. Now, the big advantage of a robot over myself or a bronchoscopist is once it's there, because of the shape sensing technology, it can lock itself in place and it doesn't fatigue, it doesn't move. So you can access the nodule repeatedly, and you can then use tools such as needles to go cross country to get into the nodule. So David Fielding and his group did the first in-human study of the ION robot in Australia, and here's a view of the computer of the airway as they're driving the bronchoscope down, and the navigation telling them which way to go essentially and how far they are away from the target. And that's how it works. That's my friend Dr. Farzad. This is the robotic bronchoscope next to him. And it's quite unusual watching this be done, because you'll have Dr. Farzad at the bronchoscope putting the tools in, and then you just have David sitting there in the corner on the iPad screen moving the bronchoscope. It's a very different way of seeing bronchoscopy happen. And as you can see, there's just publication after publication coming out with these studies. I think one of the game changers, though, will probably be the thin EBUS scope. So these are the different sizes of the EBUS scopes currently available, the 180 and the 190. There's prototypes of the thin bronchoscope coming out, and I think this is probably what will make the biggest difference, because this will allow people to get to nodules which are close to the airway, visualize directly with ultrasound, and then needle directly. Japanese technology being very obsessive, they've refined and refined and refined again the thin bronchoscope. I imagine it's a wear and tear thing. They're probably not happy with the wear rate of it at the moment, so they haven't commercially released it as yet, but Professor Yasufuki tells me it's definitely coming, and it will be one of the game changers. So this will be presented tomorrow in terms of lung cancer staging. These are some of the needle types that we use. We find that the Francine needle, which is the acquired TBNA needle there on the right of the screen, gets us really nice tissue cores, to the point that we don't use rows anymore, we just flush our tissue into formalin. So in patients who we just want tissue for EGFR status or other molecular studies, we tend to use that needle to get our samples. But even with the VisiShot needle, we've moved towards flushing a lot of our samples into formalin and doing direct histological processing, and that seems to give us a very high yield of molecular study and PD-L1 status results. So we published on our first experience of this earlier last year. We had pre-commercial access to this needle and was able to build up quite a database of patients. This was, I think, about 180 patients over 18 months, and it just showed fantastic yield, both for malignant and benign conditions and lymphoma. So the other things to be aware of for EBUS image techniques such as elastography. Some people have access to forceps biopsies that you put down a working channel, and there's been a lot of chatter about cryobiopsy down the linear EBUS scope. But I think the EBUS TBNA scope, which is thinner, will be the big game changer. So this is Felix and a Chinese group which published on this just prior to WAPIP in 2022. Of note, they only attempted if nodes were large. The sample size was almost 200 patients. Diagnostic yield, similar to meta-analysis yield in the past. You needed to do a little cut with a cautery knife before introducing the 1.1 cryoprobe. In China, they did the procedures under local anaesthetic and sedation. All patients in China had a CT the day after to look for complications. There was only one pneumothorax found. So there were 8 lymphomas, and that's where I think they thought the advantage was. There was tuberculosis, and sarcoid, which seem to be the advantageous group. So the granulomatous inflammation and the lymphoma groups, I still prefer direct histological processing. I find that using that has given us excellent yield. Of note, it was interesting that 3 cancers were diagnosed via EBUS-TBA only and missed by cryobiopsy. So I actually really love using the cryoprobe. We've extracted clots such as that with the airways intact. There's a hematoma in the middle. I've never done a pork chop, but in Australia we have a meal called the Parmigiana, which is essentially a crumb piece of meat. Then there's cheese, tomato sauce and lettuce on top. So this man actually inhaled a veal Parmigiana down his left main bronchus. And amazingly, we put the cryoprobe on it and the whole thing came out. You know, there was cheese, there was sauce, there was lettuce. I just couldn't believe that he managed to get that down his airway. So endobronchial treatment of tumours, why do we need it? You have frail patients for which SABRE is not possible. So the 3 options are thermal ablation, microwave ablation, but you need to have a hybrid theatre. So that's going to be a costly expense for many centres. I think the robot ultimately may not be the saviour for navigation and nodules, but if you want to treat endobronchially, you probably will need a robot because you'll need to lock the bronchoscope in place. So just moving on to non-cancer future thoughts, lung volume reduction where the fissures are not intact. So Professor Alvin Ng, one of our friends in Sydney, published on using glue to seal the fissure. So you get this report from the CT company, which tells you how intact the fissure is. It gives you a percentage. Then it gives you a location in terms of where the fissure is not intact. And then you're able to direct your glue to that area and then determine if the collateral ventilation has been removed. We also use ventilation perfusion in a low-bar fashion to look at effects of lung volume reduction. So I think this will be done more often in the future. In the past, a lot of the stuff was planar, it was zones. But now with new technology, you can use ventilation perfusion to look at low bar function, and this could be quite useful in lung cancer surgery in the future. So this is the glue. That's what it looks like in the airway. And there's been a couple of studies looking at it in terms of small case series and a trial which is underway. So because thermal vapor ablation lost some of its rights, the company which actually developed it then developed a different type of thermal vapor ablation. This is actually hot water rather than hot steam. And they're looking at this again in the REDUCE trial. These are not coils, but essentially implants which create an airway bypass. And the thought there is to reduce the residual volume by reducing the resistance in the airways. And this is what they look like on X-ray and then within the airway. Just in the last few minutes, chronic bronchitis treatments which are available in centres such as the Brompton, where Pallav Shah works, include rheoplasty, cryospray and targeted lung denervation. The Dutch group also do very similar studies, as well as the Austrian group. Our Australian group was involved in some of the trials, but commercially the expense has meant it's not really taken off in Australia as yet. And I promise that I did not sit down with Gary to perform, to put these slides together, but I didn't want to say too much about the pleura. I just had this one slide in here. You've heard from the pleural experts just prior to this session. So in terms of AI, I had a chat to one of my computer friends who works in AI for the South Australian government, and his comment is that the human brain thinks very differently to the AI brain. So an AI computer will go from A to Z in one step, whereas a human will go from A to B to C to D, etc., until it gets to Z. So the data that you feed it has to have all those steps in it. So if you just feed the data as the first step and the last step, you're not going to get a very good computer algorithm. So he thinks, yes, there's been an explosion in AI, but there's going to be a long time before some of the tools in it are clinically useful for us as an industry. I've noticed computer-aided nodule diagnostics. A lot of the CT companies in Australia will have this as part of their report, and they'll have a separate set of images which show CAD-detected nodules. I've actually noticed CAD fatigue from our radiologists. Some of them just get so sick of seeing the CAD, they've ignored nodules which have been picked up, and just failed to look at the computer which is there to actually help them. The AI will be really useful for navigation, I think. It's already been shown to be good at bronchial segments and navigation. It can be used to look at ultrasound images for benign and malignant lesions, and we did that as part of our study. There has been AI in ROSE, where you put the ROSE image under a computer, and then it is able to generate an algorithm of malignant or benign disease. But the data quality, that A to Z is really important. And sometimes you need a human brain to clean the data before you put it into the computer. So I think it's going to be a long time. So it's all, I guess, fun and games, and it's all interesting and it's all exciting, but I thought, maybe just one slide on what about Sri Lanka. Having been here, this is my third visit. I've presented probably half a dozen times to various conferences for Sri Lanka. It's a country which is a friend of mine, and I just think, what should we do here? And I think eBus is key. You'd favour rolling out linear first. You've got a local expert in the crowd who can help and teach, and it's because of the late stage disease and the granulomatous disease. I was speaking to a paediatric physician yesterday, and apparently 2 foreign bodies a week at least. They're tricky to get out. Cryoprobes would be great for that, would be great for tumour debulking. APC for bleeding control. We always get nervous about bleeding. And maybe these are 2 tools which you can be pragmatic with, your public funds, piggyback off your GI colleagues, maybe just knock on their door and say, look, do you actually have one of these machines already? Can we borrow it? Because Atul Mehta told me in 2007, and he repeated it in his article, which I quoted before, the future of bronchoscopy is next door in your endoscopy colleagues' rooms, because often what they're doing now we'll do in the future. So I'll just finish to say thank you to my good friends. This was from my first trip when I lost my passport in Anuradhapura, and the little girl there was actually on stage last night with Yamuna singing. Thank you.
Thank you, Dr. Phan. Since we're short of time, we can have one question. Yes, can I have the mic? Can wait.
Thank you very much, Dr. Phan, for that excellent lecture. My name is Dr. Nalakagudla, consultant chest physician. I have 2 questions for you. Actually, first of all, that we know that respiratory system is very sensitive for the foreign bodies. So, implanting a stent for a COPD patient for the lung volume reduction, would there be a temporarily, at least short-term problem with cough and hemoptysis especially? And the second one is that are there any evidence that whether the diagnostic yield using eBus needle 21 versus 23 gauge, achieving a good sample?
So the first question about cough and hemoptysis for valves, probably the most common complication is actually pneumothorax afterwards, and the one that causes us most stress. That can happen in 15 to 20% of patients. Some people get chronic cough afterwards. If you can induce lobar collapse, often that cough settles down quite well. But the cough may be due to granulation tissue or mucus retention. So sometimes I say to them, there's a third of patients which need very little maintenance. Some people, and a third of patients who are like a car, every 6 to 12 months you might need to go back in and do a washout. But I'd say that cough complication would be around about that 5 to 10% mark. And they find that the side effect of the cough is worth it for the improvement in shortness of breath. What was the second question about diagnostic yield of eBus, sorry?
The needle size.
Needle size.
Does it matter with obtaining a good quality of sample?
Yeah, there was I remember it sort of feels like, you go around in circles with needle size and other things in respiratory medicine, like inhaled steroids, that seems to change every time I go to a different conference. But for needle size, I remember about 10 years ago at WAPIP, everyone was going on about the 19 gauge needle. Like everyone was saying, oh, that's the best needle, you've got to use a 19 gauge needle. And now hardly anyone seems to use a 19 gauge needle because it was too flexible. So I think it's the technique and access of the node which is more important. And because the new Olympus needle has a reinforced tip, that has helped people access the nodes better. I think then also the important thing is speaking to your pathologist and finding out what he or she is comfortable using. Some love cell blocks, some are great with cytology, others just want tissue. So we spoke to our pathologists and they said to us, the Francine needle which we use is actually a smaller caliber than the Olympus needle. It's 21 versus 22 for what it's worth. And the tissue sizes we get with the Francine are actually bigger than what we get with the Olympus needle on many occasions. And our pathologists just prefer direct histological processing. So I think part of it is your pathologist. But you would want around about a 90% diagnostic sensitivity and around about a 80 to 90% yield in terms of ancillary tests such as EGFR and PD-L1. But I don't think the needle size particularly matters. There's even evidence that the 25 gauge needle is enough. So I think the world's moved away from needle size. Now they're looking at cryoprobe. Every course which WAPIP gets asked to approve, everyone seems to be doing cryobiopsy of the nodes, and I just haven't found a big use for that as yet.
Thank you, Dr. Fan.
So quick
There's one
question. So I'm a radiologist.
Yes.
Takes me about 12 minutes to do a 5 mm peripheral lung nodule biopsy.
Yeah.
And I just don't see the point. I know that eventually y'all will do it because the patients are yours, they refer to us, and so you can pretty much do the biopsy. But really speaking, why? When it takes so much effort, so much instrumentation, we can do it like that.
So 5 millimeters?
Sorry?
5 millimeter nodule?
4 and
4.
5. And
But why are you biopsying a 4 millimeter nodule?
because it needs to be biopsied. Somebody needs to know whether it's granuloma or metastatic disease in a patient who's got
Yeah.
osteosarcoma.
Yeah.
How do you know that? So you need to biopsy these, right?
Yeah.
So if we can do those, we can do the 1 centimeter, 2 centimeters,
Yes.
very easily.
Yeah.
So the question is, why all this?
Yeah.
I mean, I know you're pushing the envelope, but
Yeah. Now, I triage all the lung nodules in our centre, and I have a very good relationship with our radiologists. So if it looks like a nodule which a radiologist is better at, I send to them. Some of the more central stuff, and they may not be comfortable accessing it because of pneumothorax or bleeding risk, we attempt first. So it's a collaboration, it's a discussion within the team. So some of these reasons for doing it is, I think, safety. Now, pneumothorax rate is around about 15 to 20% for CT guided biopsy. Probably only 5% might need a chest drain, so not all of them get admitted. Hospitals in Australia are driven by day patients. They don't like to admit patients. So that's one reason. There's often less bleeding risk as well. We've had, unfortunately, some cases of significant bleeds from CT guided biopsies. That's made some of our radiologists a little bit nervous. So I think those two reasons have driven driven ultrasound guided and bronchoscopic guided biopsies. Now some centers have radiologists like you who will biopsy a 4 millimeter nodule.
I guess,
just one last second. The challenge is that, like with TBNA and EBIS-guided nodal biopsies, where the guidelines today don't even mention CT-guided nodal biopsies or ultrasound-guided supraclavicular node biopsies, which are simple, simply because the guidelines are now written by people who are doing TBNAs and EBISs. The worry is that 5 or 10 years from now, the guidelines will keep saying only do radial EBIS, only do bronchoscopic-guided nodal biopsies, and while practically we're still doing node biopsies day in and day out, the guidelines just don't mention us anymore. And that's the worry, that eventually that's the path that will be taken, because there are no radiologists involved in writing these guidelines.
I promise you I'll never do an EBUS on a supraclavicular node, and I promise you I don't have a radiologist who will biopsy 5 different stations, so that's why we do EBUS staging. So I'm happy to chat to you about it afterwards. Yeah.
I will wrap up the session. We can continue over the tea. I think because we need to move on to the next session, we will be wrapping up this session. Vipula will present a token of appreciation to Dr. Fan
No worries.
on behalf of the College of Pulmonologists.
And with that, I cordially invite our chairpersons to present the token of appreciation to our speaker.